This is an overview of an article entitled Impact of Apolipoprotein a Isoform Size on Lp(a) Lowering in the HPS2-THRIVE Study, published in the February 2018 issue of Circulation, Genomic and Precision Medicine. Lipoprotein a, or Lp(a), is formed by a low-density lipoprotein particle characterized by the presence of apolipoprotein a, or Apo(a), a protein with a genetically determined variable number of Kringle-4, or K4, domains that define Apo(a) isoform size. Lp(a) levels are strongly inversely associated with the number of K4 domains and vary widely within and between different ethnic groups. Large studies of two genetic variants that are associated with lifelong higher Lp(a) levels have provided evidence of a causal association between Lp(a) levels and cardiovascular disease. HPS2-THRIVE was a randomized control trial of niacin laropiprant versus placebo on a background of simvastatin therapy. Niacin, also termed nicotinic acid, lowers Lp(a) substantially. It also lowers LDL cholesterol and raises HDL cholesterol. Laropiprant does not affect lipids, but was used in combination with niacin to inhibit the flushing side effect of niacin. Despite the ostensibly beneficial effects of niacin, HPS2-THRIVE showed no benefit with respect to cardiovascular risk. In the paper under discussion, an Lp(a) substudy was undertaken in HPS2-THRIVE to better define the effect of niacin on Lp(a) and Apo(a). Plasma Lp(a) levels at baseline and 1 year post-randomization were measured in about 4,000 participants from the UK and China. Apo(a) isoform size, estimated by the number of Kringle-4 domains, was measured by agarose gel electrophoresis, and the predominantly expressed isoform was identified and used as the primary metric for Apo(a) size, rather than using data about coexisting less abundant isoforms in the same samples. As expected, there was a strong inverse relationship between the plasma Lp(a) level and the number of K4 domains in the predominant Apo(a) isoform. For a given number of K4 domains, Lp(a) levels tended to be higher in Chinese than in UK participants. The top panels of this figure show Lp(a) reductions with niacin at 1 year compared to placebo, with the cohort divided into quintiles by baseline Lp(a) level. The bottom panels show Lp(a) reductions within quintiles by predominant Apo(a) isoform size, as represented by the number of K4 domains. The left panels show the data as relative reductions in Lp(a), and the right panels show the data as absolute reductions in Lp(a). The overall relative reduction in Lp(a) was 31%, but attenuated from 36% down to 18% across quintiles by increasing baseline Lp(a). Notably, the relative reduction attenuated even more strongly across quintiles by decreasing K4 domain number, varying from 50% in the highest K4 quintile to 16% in the lowest K4 quintile. In contrast, there were increasing absolute reductions in Lp(a) across quintiles. The upshot is that the impact of niacin varied more substantially with Apo(a) isoform size than with baseline plasma Lp(a) level. Also notable is that the degree of coronary risk reduction with the observed Lp(a) changes would be predicted to be quite small. For the entire cohort who received niacin, the mean absolute reduction in Lp(a) was 12 nanomoles per liter, which should translate to a 2% reduction in coronary events. Even for the patients in the top quintile by Lp(a) levels, in whom the absolute reduction in Lp(a) was 34 nanomoles per liter, there would only be a 5 to 6% reduction in coronary events. This is consistent with the failure of niacin to significantly reduce coronary events in HPS2-THRIVE, although this of course ignores the pleiotropic effects of the drug on other lipid traits and possibly additional traits that might influence cardiovascular risk. In conclusion, the predominant Apolipoprotein isoform size was the strongest determinant of the efficacy of Lp(a) lowering by niacin. This should be kept in mind when considering the effects of other therapies on Lp(a) lowering. Furthermore, the preeminent role of Apolipoprotein isoform size seen in this study might give insight into the molecular mechanisms that determine the plasma Lp(a) level. Finally, it's clear that much more potent Lp(a) lowering therapies will be needed if a substantial degree of coronary risk reduction is to be achieved.